Hello everyone, my name is Becky Farley and I'm a physical therapist and I'm the founder for Parkinson Wellness Recovery. So welcome to the talk today. I'm going to give a foundation about Parkinson disease, an overview, and I appreciate you watching the video. I usually give this talk at the retreat, but it takes a lot of time and it takes time away from other really important things like exercise and how to deal with the non-motor symptoms and neuroplasticity. So I'm very excited to put this in online version. You will receive the slides after the retreat. You'll get the slides of all the speakers and other handouts that we have. So thank you very much. I won't be this big life size the whole time. I'm going to switch modes so that you'll see a little box up in the right corner where you can see me, but mostly it'll just be the slides. The purpose of the talk is to give you a foundation and language for the partners and the people with Parkinson disease so that everyone has a common level of understanding. I'm going to talk about the prevalence and incidence, who gets Parkinson's, and then I'll spend time on the cause of Parkinson disease. There'll be a little break in there. And then I'll end with medications and deep brain stimulation. So you can fast forward this if you'd like, but there's so much new information on alpha-synuclein and the gut and the causes of Parkinson diseases and new therapies that I find this all very exciting. And it motivates me all the time to stay on top of the literature. So I'm doing my very best to make it information that can help you in your fight with Parkinson's and give you good background so you can communicate with your physicians and the speakers at the retreat. So thank you very much, and I'm going to switch modes and get started. All right, so I want to talk first just about some facts about Parkinson disease. It was first described by a British surgeon, Dr. James Parkinsons, in 1817. He kept this amazing book, which you can get online at Amazon. It's about 6 cases that he observed, and he was probably one of the first physicians to really write the job description for a neurologist. It's the second most common neurodegenerative disease after Alzheimer's, and in fact there's a story we'll talk about that there's really an epidemic over the next 25 years. It's the most common form of a clinical syndrome called Parkinsonism. We'll talk about what that means. The diagnosis requires a neurologist using their skills, their clinical skills, to identify the cardinal motor symptoms, which are a resting tremor, rigidity, and bradykinesia, which means slow and small movement. These are physicians that specialize in movement disorders, and just seeing a physician that is a movement disorder specialized physician can improve the accuracy of your diagnosis, the speed at which you get that diagnosis, and your quality of life, and even things like reducing hospitalizations and decreasing the rate of fractures, things like that in the long term. The first motor symptoms for Parkinson disease appear when 50 to 60% of the dopamine neurons have died. In 1961 is the first time there was a successful clinical trial using Levodopa, which is still the gold standard medication for people with Parkinson disease. Right now, they're trying to find out how to really focus on better delivery so that there are fewer side effects and that it can be maintained at a chronic sort of dosage over the course of a day instead of fluctuations. So there's a lot of new potential delivery systems for levodopa, or it's always given with carbidopa, so it's called levodopa carbidopa or Sinemet. All those are the same thing. Exercise is medicine for people with Parkinson disease. It truly is a physiological tool to create change from the inside. We'll talk more about that at the retreat, but it's my motivation because there is more compelling data on the role of exercise in Parkinson disease than any other neurodegenerative disease. And I know you have a lot of potential to get better and stay better. It isn't easy. As it says, the caveat of exercise is you have to move. But despite exercise and medication, there's still a battle or a barrier that we have to help you improve your participation in life. Because that continues to be a problem. It's not enough to just exercise 3 days a week. It's really about doing the things that you love, overcoming postural instability and gait disorders like freezing of gait, problems with turning, and musculoskeletal complications, things that the rigidity is constantly pulling you into flexion and causing problems at the shoulder and the hip. So you're going to still need targeted rehab and coaching for life. And we'll talk about and define that at the retreat next week. Exercise, the good news about it is it may actually reduce the amount of medication, your need for medication over time. This is not Parkinson's disease. In this picture, there's really a revolution of people trying to ban this picture from textbooks and medical talks. It has since 1960s been the picture that represents Parkinson's disease. And Anders Lines, he was a Norwegian video journalist. I met him at the World Parkinson Congress in 2016, and he put on a whole exhibit. It took up the whole reception area practically, showing people new images to represent people that have Parkinson's disease. It's quite remarkable. You can go to his Facebook page and see what the exhibit looked like. People are starting to use his pictures and images. He's making them available so they can be used in medical talks, and hopefully in the future we will get rid of this sort of image of older males, shuffling gait, stooped posture, because there's a lot more to Parkinson's disease than that. That kind of image also does a really negative, form of education to the public, as well as for people with Parkinson's disease. It's overwhelming to see those pictures, especially when, if you were to poll 3,000 people living with Parkinson's disease, and they were asked what's the most challenging aspect of living with Parkinson's disease, stigma, if you'll look at that list, stands out as the most challenging issue. So we don't want to do anything to add to that sort of negative plasticity that's occurring, and that tendency for the brain in Parkinson's to really absorb negative thoughts. We want to empower people with education and shine a new light. So this is one of his images. This is Parkinson's disease, people of all ages, all walks of life, people with disabilities and seniors and farmers and CEOs, and there's many of these images. These are probably mostly Norwegians because that's where he lives, and I got to meet him. He's on the far left when I was there, and he is continuing to take this on the road. So the prevalence represents a total number of people living with Parkinson's disease in the world or in the US. It's the least accurate of the statistics because, well, some countries don't have health care, they don't have a neurologist, they don't have really statistics. And although that is improving greatly, people in some countries are beginning to do door-to-door surveys, training people in the community to recognize Parkinson's, trying to identify how many are really around in the world. Current stats would say that there's per 100,000 people, there are 100 to 347. The rate increases with age. You can see on the right, starting with 30, going up to 80. It goes up in terms of about 1 to 4%. Men and women, there's a greater risk for men, greater prevalence in men. 85% of the people with Parkinson's are over 65. However, 15% of them were diagnosed before 40 years old and living with it longer. Idiopathic, 90% of the cases, really have an unknown cause, although we'll learn there's more and more understanding of the genetics and maybe different causes. Hereditary, people with familial Parkinson's and have family members, even if it skips generations, is around 10%. And I'm sorry, hereditary is when it's in every family, monogenic, versus having it in a relative, 15 to 25%. So recently, Alison Willis, for her dissertation and now continuing to work on in this area, was one of the first to use the US Medicare database to really try to get more accurate measurements, at least in the US, of the number of people living with Parkinson's disease. You can see worldwide, there's a greater prevalence in Europe and North and South America than some of those other countries. As far as it goes in the US, ethnically, Hispanic more than non-Hispanic, white more than Asians, more than Black. The geographic distribution, she was the first to recognize this through the database, that it's 2 to 10 times higher than Western and Southern US counties, and she's called it the Parkinson Belt. And then and you can see that there's, a very dense population, industrial part of our country. You'll notice in the green, where Arizona's down there on the left, that's only because most of the people that live in the Northeast, it must be summertime and they're not visiting Arizona, because we get a lot of people with Parkinson's visiting or coming to specific areas where they live and retire. So I encourage you to watch the Michael J. Fox Foundation's Third Thirsty webinars. You can go on his site and even view the past ones, which this was one of them from March 15th. And Dr. Boss Bloom and Ray Dorsey, two leaders in the field of movement disorders, had a conversation and were interviewed by Dave Iverson, who does have Parkinson's disease, and he's been a journalist his whole life with NPR, and he does great seminars. So this one was really about this concept of an epidemic, and they proposed that since 1990, the prevalence has doubled, and they anticipate in the next 25 years that will double again. Why is that the case? When people are living longer, there's also a decline in smoking rates, and you're going to learn that smoking is protective for Parkinson's disease. Not something you should do, but a lot of research is looking at what are the components of nicotine that may be protective, but because there's fewer people smoking, that may contribute to a greater prevalence. Also, there's a lot of underreporting, like I mentioned, for prevalence. It's hard to identify where people are. Not everyone goes to a doctor, much less a movement disorders physician. They may never have access to anyone but a primary care, and so often they don't get reported. Their primary directive of this webinar and purpose was to talk about the needs to advocate and take action. And they suggested for research funding, for one, with that kind of prevalence and anticipating doubling again by 2040. Banning harmful pesticides. So there are so many toxins in the environment that have been shown to contribute to Parkinson's disease and other neurodegenerative diseases. However, they are still available, many of them. And even if they do ban certain ones and they're taken off the market, they're still in the soil and getting into food and for feed for animals and all of that. So it seems the very least thing that we can do is start with how the environment, what role can we play in the environment to reduce risk factors. We can also increase protective factors like exercise and rehab services that definitely may be protective, as well as can help people live longer and better with Parkinson's disease. and a balanced diet may play quite a role, especially with the role of the environment and gut. And so we'll talk a little bit about that, and we'll have a speaker at the retreat who will go into more detail. The incidence is the number of people who are newly diagnosed every year. These numbers are a little more accurate, and across the overall incidence is 14 to 25.6 people per 100,000. The more people living that are over 65 in any one region, of course, you're going to have more newly diagnosed people. In Tucson, you can see at the bottom, we have a population of about 600,000. So I've just estimated how many I might anticipate every year being diagnosed. And our goal at our PWR gym in Tucson is to try to find a way to meet the needs of those people. It's a big challenge, and it's going to require some new paradigms. The age of onset typically is between 55 and 65 years. There is a younger group. You can see the percentages are 10 to 15% that are diagnosed between 21 and 50 years old. And there is a later onset Parkinson's. In each of these age groups, of course, they're going to have different levels of fitness, different interest in fitness, different numbers and types of comorbidities. Their motivation and personal goals would be different. They will even respond to medication or exercise differently. And in fact, everything we know about medication and exercise, all of that research is done in this group of typical 55 to 65-year-olds. So there's very few large studies on both exercise and medications for these other groups. The diagnosis of Parkinson's, well, it starts with, there are official diagnostic criteria from the UK. You can look them up. I have the reference at the bottom. And the first thing is to diagnose Parkinsonian syndrome. So the absolute most important symptom that a physician will look for clinically is evidence for small, slow movements. That's not just voluntary movements, but those are postural responses to the loss of balance. So that's both voluntary and automatic sorts of responses. Bradykinesia is the #1 most highly correlated symptom with dopamine levels. More bradykinesia, increased loss of dopamine. And bradykinesia is really a force regulation problem. The brain is not driving enough force for the needs of the task. So movements come out too small, too slow. The other thing they look for is one of the following: either rigidity, which is really this co-contraction that contributes to the loss of musculoskeletal, your alignment, your posture becomes stooped, the shoulders are tight, the hips are tight, all of that limits and affects your balance and mobility, and it can contribute to pain. Or they look for a specific type of resting tremor and or some loss of postural instability or balance problems. They're not caused by sort of the other systems like vision, vestibular, other parts of the brain. That's something that they would relate to having Parkinson's disease. So bradykinesia first is the hardest thing to measure, especially in early diagnosed people, because most of the time you can override bradykinesia early on. And the physician, in order to test if you have it, may need to have you do things under cognitive load or dual tasking, multitasking. They may want to watch you move when you don't know it. So they might have you move around the room or walk out and come back. So that's one reason they can't diagnose it right away, is if they don't see bradykinesia. So it's important that you also note it yourself at home and work. And if you have noticed that it's just taking you longer to get ready in the morning, that you're just having more difficulty with one side of the body, getting it to go fast enough. The next thing they do is they just try to rule out any other kind of criteria or diagnostic, from a diagnostic perspective, rule out other diseases. So they have a whole host of things that they would go through just by watching you over the course of 6 months to a year or more. And this gives you another idea of the number of things going on in the brain of a movement disorder specialist. They're thinking about in the center, is this person idiopathic Parkinson disease? Or do they have one of these other types of atypical or secondary Parkinsonisms that have a different progression? They involve different parts of the brain. The ones on the left, secondary, may be things that will not progress as fast, or they might go away if you remove the tumor or you remove the drugs that may be inducing those symptoms. So you can see there's a lot of things that they have to follow, because there's no specific test for idiopathic Parkinson disease, that they have to try to do clinical tests and observations. Sometimes they do MRIs and other things to rule out. Again, everything we know about Parkinson disease and medications and exercise is in that center group. And the good news is that 75% of the people that go see a movement disorders physician to be diagnosed with Parkinsonism turn out to have Parkinson disease. So that is good, because that is what they know the most about and have the most therapeutic options in terms of meds, surgery, and exercise to offer. Finally, after they are fairly confident that this is Parkinson disease, they're going to continue to look for 3 or more of the following positive criteria that's required to have definite Parkinson disease. So, are your symptoms on one side of the body, and do they stay on one side of the body? You may get symptoms on the other side, but they're always worse on one side. Is it progressing, or are the symptoms been the same over the past 2 and 3 years? Again, persistent asymmetry. It starts off one-sided, and there's really no specific. Insidious just means you can't really pinpoint when it started. It was so gradual. If you respond to levodopa when they give you your first dose and you have a great response, you get a kick, that's a very good indication that you have Parkinson's disease. If you are sensitive to the medication and over time you develop these dyskinesias, which are involuntary movements, they can be really small in the extremities, the neck, the jaw, the face, the head. Also, they're going to see if you continue to respond to levodopa over the course of 5 years or more. You may not think you are, but if you were to stop taking the medications and be tested in an off condition, your symptoms would be worse. And then over the course of 10 years or more, they would have specific expectations and be able to, and all of those, 3 of those would be enough to decide that you have definitive Parkinson's disease. So unfortunately, it does take a while. It takes this really neurologist with a very good set of clinical skills and someone who sees a lot of Parkinson's disease. That will only make this process faster. But that doesn't mean you need to wait for the diagnosis. Even if you have nothing but some slow movements that are worse on one side of your body, that's the time to start exercising. It's so important. That is a window of opportunity to really use exercise as medicine. So like I mentioned, 75% of the people that are diagnosed with Parkinsonism at the beginning turn out to have idiopathic Parkinson disease. And again, we can almost predict how you'll respond. So when I do assessments and I get to see people in the gym with Parkinson's disease, I know from the very beginning, after watching them and having them move and exercise with me, I can predict how good this person's going to respond if they have Parkinson's disease. If someone comes and I do that assessment and they have some other type of Parkinsonism, it's much more difficult for me to know what is the best exercise program or how this person will respond to different types of exercise. So it makes it much more challenging. And also that is why people that have any sort of atypical progression or response should definitely see a physical therapist right away. I think everybody should, but those individuals should not wait. They need to be started on a progressive program ASAP. Everybody does, but especially those people. There are different types of even idiopathic Parkinson disease. Some people have a tremor, and that's the primary symptom. Maybe a little slowness, but the tremor is the thing that bothers them the most. And other people have more rigidity, and it affects their gait and balance, postural instability more. And that's abbreviated the PIGD, postural instability, gait difficulties. Then there's people that have sort of more of a mixture. So there's probably many, many more types of these sort of subtypes of idiopathic Parkinson disease. And the more we understand these subtypes, the better we can develop targeted exercise approaches, and I'm sure also targeted approaches to medications and surgeries. So what other things do we know about the differences of people with Parkinson disease? Well, the tremor is slower progressing than the PIGD subtype. The posture and gait instability group also is associated with faster rate of cognitive decline and a higher incidence over the long term of dementia. People that are a little bit older and have the later onset Parkinson disease have a greater risk of getting the Parkinson's and gait disorder. Younger onset Parkinson disease, their distribution of symptoms is different. They have more tremor, more rigidity, more dystonia, which is this cramping that can be in the hands or feet or the trunk, and a higher rate of dyskinesias, which is again a side effect of the levodopa medication. Women have later onset Parkinson's disease more typically, a higher prevalence of tremor, slower rate of motor impairment. The non-motor symptoms in women can be characterized more by the emotional symptoms of anxiety, depression, and constipation, which is an autonomic symptom that can occur even 25 years before Parkinson's disease. In men, the non-motor symptoms are more likely to be sleepiness, daytime sleepiness problems, drooling, sexual symptoms. So this is all new. I went to the first Women in Parkinson's Disease conference, I want to say 3 years ago now, which was amazing. And that group of women are training other women to be support group leaders for women, and they're trying to establish research priorities for women and gender research. So I think that's a huge contribution, and ever since then there's been so much more research come out about the differences between men and women in response to medication, exercise, other things like that. Hi again. Okay, so let's start on the next section, which is more about the cause of Parkinson's disease. So let me switch screens. All right, a little bit of neuroanatomy. I just want you to be familiar with where the basal ganglia are in the brain. They're subcortical structures, so the gray you see around the edge, that is the cortex. It's the most outside. The areas lit up in yellow, green, and colorful, those are different nuclei, which is a group of neurons all together, and those represent the basal ganglia, different parts of the basal ganglia. The part there that is black is called the substantia nigra, and that is where the dopamine neurons live. That's called the midbrain. And the reason it's black and labeled substantia nigra is because dopamine neurons are always associated with pigment or melanin, and so that part of the brain is black in color. And it turns out that probably that pigment may play a role and potentially contribute to one of the causes of Parkinson's disease. So you can see the white arrows going up from the substantia nigra, where the dopamine cells are projecting up to these different regions and communicating with the cortex, the higher levels. Your cortex is what tells your muscles what to do. This basal ganglia is just simply, it's modifying those signals. It's sort of fine-tuning the signals to the muscles. The cortex is involved in voluntary movement and everyday habitual movements. So all your, getting out of car, getting out of bed, getting up from the floor, things you don't think about at all, that's what the basal ganglia is specialized in controlling. There's also a white arrow going down lower into the brainstem where the dopamine is also important because it's related to the automaticity of walking, how to integrate your balance and your trunk movements with your other arm and leg movements, gesturing, breathing, eye movements, all those little things that happen spontaneously when we communicate, when I'm moving, are no longer as spontaneous in Parkinson's disease because there's a problem regulating the forces and the signals and the timing of the signals to the muscles. So those automatic things that we do every day become more difficult. Voluntary movement, just one purposeful movement, just step or reach, is not as difficult as more complex everyday movement. So the more sequences, the more that you change position in space, the more difficult those skills are for people with Parkinson's disease. I like to think about the basal ganglia because the more I understand it, the more I can think about how can we develop exercise programs to target the specific pathways, because we want you, right, to activate these pathways as soon as possible, even though they're damaged or they're not operating as efficient as they should because they're lacking dopamine. Doesn't mean they can't improve their signaling and improve the strength of these different pathways. So there are 3 different circuits that run through the very same regions of the brain. One is involved in the motor, so driving force regulation through the limbs, and that's responsible for the symptoms of bradykinesia, rigidity, and tremor. There's also cognitive circuits in parallel through these same parts of the brain involved in problem solving, high-level problem solving, which is executive functioning, being able to make quick decisions, when to go, when to stop, inhibiting the noise and distraction out there so you make the right decision. Requires a lot of attention and the ability to divide your attention back and forth between multiple tasks. So that's what the role of the cognitive circuits in Parkinson's disease do. Then there are also emotional circuits related to reward and fun and humor and creativity. And this is really what underlies the depression, the apathy, and anxiety in Parkinson's disease. And so by having therapies and approaches that target these different things, so physical high effort exercise can target your motor circuits, requiring people to make quick decisions during exercise or dual task or have to think and problem solve through different environments with exercise is challenging the cognitive aspects of Parkinson's disease. And then the emotional circuits are involved in giving you feedback, reward, making the task important to you or fun, so that you're more engaged emotionally. So it's really important for us with an exercise program to target high physical effort, high cognitive engagement, and emotional engagement. That's the secret. That's the art of a good exercise program. So if you could look in that part of the brain, in the midbrain where the substantia nigra neurons live, you would see on the left this black substance, and that's where the dopamine neurons are. And someone that has a healthy brain on the left, no Parkinson disease, the red represents axons from those neurons projecting up into the basal ganglia where they release dopamine. On the right, you see someone with Parkinson's disease, and again, already at diagnosis, 50 to 60% of the cells in the substantia nigra have died at diagnosis, and this process of cell death may precede the diagnosis by 5 to 20 years. At the same time those cells are dying, some of them are just sick and maybe inefficient, and perhaps they could be rescued or work more efficiently with the right kind of exercise, or in the future with a medication or supplement. And there is evidence that exercise can actually help the sick neurons be more efficient and work better. And that might, but the process of using them and keeping them functioning better may actually slow the disease progression. So if you could look, let me go back, if you could look at the putamen and caudate here, and where those neurons are projecting to and releasing dopamine, you can actually quantify with different types of PET imaging, F-Dopa PET or a DAT scan, and you can visualize the loss of dopamine. So you see a healthy control on the left, you see this bright yellow representing the amount of dopamine that's in the area. On the right, you see someone with Parkinson's disease with a significant, probably a 70–80% loss of dopamine on the right side there, which represents in perhaps a person more worsening of the symptoms on the left side of the body. Whereas on the other side, they may not have motor symptoms yet because there's not as much of a loss of dopamine. So that's one way of imaging dopamine. And again, research, this is expensive. The DAT scans are used often by neurologists to rule out other disease, to try to really verify, is this a dopaminergic neurodegenerative disease? Is it related to the dopamine system? Because they can measure and see what the effect is on the release of dopamine. Still, unfortunately, to truly diagnose Parkinson's disease, the pathological hallmark of the disease is found by doing autopsies on people that have died and looking into the substantia nigra. Again, on the left is one from someone that did not have Parkinson's disease. You still see the pigment, and if you could look at a microscope, you'd see a lot of dopamine neurons. On the right, you don't see any more pigment, and if you could look under a microscope, you could actually try to count the neurons that were left. And you'd also see a lot of dead dopamine neurons that look like this. They swell up, and there are these balls, these kind of clumps inside that are round, and it turns out those are alpha-synuclein aggregates, and we'll talk more about that. They call this image of a neuron like this, a dopamine neuron, with these clumps inside of them, Lewy bodies. And again, this is a classic hallmark of Parkinson's disease. And if they see this post-mortem, that would be the final cause of death, or a confirmation of definite Parkinson's disease. So what is causing Parkinson's? What are the factors? What are the real mechanisms that are causing the neurons to die? We're going to talk about the fact there are now genes that have been identified that are associated with the symptoms of Parkinson's and in some cases Parkinson disease or Parkinsonisms. Also, there are definitely things in the environment that cause Parkinson disease. And then there's this interesting relationship between genes and the environment we have susceptibility genes that might make us predisposed or more sensitive to environmental toxins that, say, come through your food and gut or through your olfactory system and through respiration and things that you might be exposed to. So it's not a simple solution. It's actually very complex, multiple causes. It's multifactorial, but it definitely has a relationship to aging, environmental toxins, genetic factors, and this sort of environmental genetic interactions through our lifestyle, what we're all exposed to and what we're susceptible to genetically. So as of 2012, there were more than 18 specific chromosomal regions identified that were related to risk of Parkinson's disease or a cause. Even now, not all have been confirmed to be causative. They don't necessarily know what they all do, but they're associated with people, individuals that had some Parkinsonisms. Also, they don't all have the same inheritance pattern. They could skip generations, or they could be in every family member. So they know that there is this effect that just because you have a gene doesn't mean you're going to get Parkinson's disease, and it may be a gene that's more related to other factors in the environment. Only 10%, and let me just say that those 18 chromosomal regions have been labeled Park 1, Park 2, Park 3, all the way through Park 18. And there may even be more now. I can't keep up with all of the research on this, but only 10% of the cases do report a positive family history. And so they've been able to show that at least 2 of these regions of chromosome are related to 2 genes, the SNCA or LRRK2, that are autosomal dominant forms. And then several others, I think I listed 4 there, are autosomal recessive forms in people that have a positive family history. Again, these different forms, the Parkin, the pink one, the DJ1, ATP13A2, those are, again, associated with different age of onset, sometimes a little bit of different symptoms. So some may have more cognitive components, other more tremor or gait. So, you know, when you think of how different every person is with Parkinson's disease, it's really not a surprise that there may be many different genetic contributions to Parkinson's disease, as well as environmental, that creates the heterogeneity that we see in individuals. Just because you have a you have a gene that's been labeled as a Parkinson's gene does not mean that you will get Parkinson's disease. But it is a really good way to study people over time longitudinally to see what does happen. And so many studies are trying to say follow people with the LRRK2 because it is in every family member would be expected to have that gene. So if you can follow them over time and see who gets Parkinson's disease and try to understand what are the other components that may have contributed to that, and also can there be early proactive, like disease modifying ways to intervene, like with exercise or nutrition or lifestyle reducing stress. So those are probably going to be the first individuals who will really be candidates for these types of neuroprotective strategies. And also they will provide a really good way to understand it better. They're trying to find biomarkers, say, that these individuals have, like do they have constipation over time? Do they develop loss of smell, and when does that happen? Do they have difficulties with sleep? So the more they can understand all these other non-motor associated symptoms and how they develop over time, it will only help in earlier diagnosis in the future. So this is an interesting figure from this article that was published in 2017, showing on the left risk factors for Parkinson's and on the right protective factors. So the larger it is, the more evidence there is. And so you see on the left as a risk factor pesticides. There's definitely evidence for pesticides, which just raises other questions like what about solvents and what about other things that we may be exposed to chemically. Dairy has been associated with risk for a lot of different neurodegenerative diseases. Is it something that in the soil, in the food that these animals are eating? People with Parkinson's have a greater risk of getting melanoma, and that relationship of melanoma, and again, skin and pigment with Parkinson disease is still not well established, and why. But because people with Parkinson's have more melanoma, then that is a risk factor. And frequent head injuries, traumatic brain injury there is some evidence that can contribute over time. In terms of protective factors, I also mentioned on the left as a risk factor this new idea of your gut microbiomes and how we all have a different distribution of those in our bodies, and that some people may have microbiomes that are more protective of certain things in the environment than others. And that could be an entry point for toxins into the nervous system. So protective factors, smoking I mentioned. So there's a study looking at a nicotine patch that I think is in a phase 3 clinical trial. We'll learn more about that at the retreat. Caffeine, yay, is protective. So don't put down that coffee cup. What is it about caffeine? They don't necessarily know. They're trying to identify it, of course, to isolate it. It's also interesting that urate levels in people with Parkinson's are low, and people with gout, where the urate levels are high, have a lower probability of getting Parkinson's disease. So this is interesting, and again, there's some clinical trials going on looking at monitoring urate levels and trying to help increase the levels in people newly diagnosed with Parkinson's to see if that can slow the disease progression by optimizing the urate levels. The secret is in optimizing the urate levels without creating gout. So, but it is looking really promising. Again, physical activity, exercise, protective factors. In anti-inflammatories, specifically ibuprofen, seems to be protective for neurodegenerative diseases and Parkinson's disease. And then also calcium channel blockers. So there's a drug called isradipine, and it seems like it is really important to keep calcium controlled in the nervous system. So usually it's not, you can't accumulate a lot of calcium either externally or inside a cell without causing some sort of toxicity or damage. So these channel blockers, which are kind of constraining calcium, keeping it where it belongs, might be important. It also, all of these protective factors open up the door for nutrition and supplements, antioxidants, anti-inflammatories, nicotine patch. So a lot of research is going on in this, and this is a great review article if you're interested in this area. So, my favorite figure, um, I didn't make this interactive, so just ignore the exercise words for now. But there's several different mechanisms that are thought to really trigger cell death. And of course, if you can stop that mechanism from happening, you have a potential cure or a way to stop or halt the disease, which would be neuroprotective. So at the top, you see deficient neurotrophic support. Neurotrophins are essential. They're the Gatorades of the brain, and they're specific to different neurons. And the dopamine neurons particularly love one called GDNF or BDNF. And these neurotrophic factors help the cells operate smoothly, efficiently, reduce the stress, oxidative stress inside the cells, and actually it's responsible for the survival of the cells. So to stay alive and do all this work they do every day, making proteins, destroying and proteins, they need a lot of food and substance, and that's what the neurotrophic support is. People with Parkinson's disease have low neurotrophic levels when you measure those two neurotrophic factors. Let's go to mitochondria dysfunction. So your mitochondria are really your energy storehouses in a cell. Every single cell has mitochondria. This is where they make ATP. This is it's a machinery inside the cell that does a lot of like industrial factory stuff that you got to keep it. If the mitochondria gets sick, then that can create havoc and toxicity inside the cell. And unfortunately, the mitochondria are not functioning well in people with Parkinson's disease. And this is not just in the brain, but also in the muscles. And the cells can actually go into an energy crisis. And I think of this as sort of perhaps a mechanism that underlies fatigue. If your cells are not getting enough ATP, they can't work efficiently, they wear themselves out, and it makes me think of the fatigue that people with Parkinson's have. Another mechanism is called oxidative stress. And anytime this is happening, like when a cell is making a neurotransmitter, they have to make a lot of neurotransmitter and send it out down into the synapse. They're mixing chemicals, they're creating things, destroying things, little chemistry labs, and there can be the potential for oxidative stress. And I mentioned that dopamine neurons are associated with melanin or pigment. And it turns out that when dopamine neurons make dopamine, it's a very highly oxidative process, and there can be damage and interaction with pigment if it's not going well. And so cells that make dopamine that may be one reason they're predisposed to getting sick, because they're right in the vicinity, there are cells with pigment. And so the level of oxidative stress can be high. And it is high. The substantia nigra has high levels of oxidative stress in people with Parkinson's disease. Finally, I want to mention one of the other mechanisms that is actually super interesting, I'm going to talk more about, is the fact that the cells actually, every cell has to make proteins. So these are critical elements that have jobs to do inside the cells, at the synapses, neurotransmitters. But they also have, these proteins are only good for like 24 hours, so they have to then go and destroy those proteins and have a way to get rid of them, because an old protein is toxic to the cell. So cells have a lot of different ways to eliminate garbage disposal mechanisms. And in Parkinson's disease, it turns out that their garbage disposal machinery is impaired, and that this specifically affects a protein called alpha-synuclein. So the alpha-synuclein builds up inside the cell and in the outside of the cell in the extracellular space, and it becomes toxic, it clumps, and we'll talk about that. So anything that it can improve the garbage disposal machinery in a cell could potentially keep the cells alive longer. And it turns out there's already a lot of medications for that for other types of diseases, cancer for instance. There's a lot of reasons why a cell needs to have garbage disposals, and so other diseases have developed drugs for that. So some of those drugs may be helpful for people with Parkinson's disease. So the bottom line is you have all these mechanisms and it's not very clear which comes first, and in fact it may be that oxidative stress happens first, and that triggers problems with the garbage disposals, and then that affects the mitochondria function, or the other way around, or perhaps in different types of Parkinson's disease, subtypes, these mechanisms may shift and be prioritized differently. So it's not really clean, but if you can help with one of these mechanisms, you may be able to help slow cell death, which would be evidence for, it would be a disease-modifying treatment. It may not be protection, but you're actually slowing the cell death. And then I have up there in blue, exercise. So start with neurotrophic factors. Exercise has been shown in animals and humans to promote neurotrophic factors, specifically BDNF, and that's a really great thing. So that could provide more trophic support for those sick, vulnerable neurons. That's one reason exercise may help so much. 2, exercise can improve the energy production in a cell. And that has been shown that after exercise, the mitochondria, both in the brain and in the muscles, is improved. So you get more energy, you get more ATP, the cells stay alive and work harder, more efficiently for longer. 3rd, exercise has been shown to help reduce oxidative stress. So I can't, there you go. There's 3 different ways exercise can help with different mechanisms. And I also put on the far right, there's other types of potential protective or disease-modifying things out there that are being researched that we'll talk about at the retreat. For instance, nutrition and supplements. Creatine is a supplement, and it can improve mitochondria function. Sleep can reduce oxidative stress. So, and sleep is a major symptom, a negative factor in Parkinson's disease. Meditation can also have an effect on stress management and these oxidative responses to stress. On the left, in terms of the garbage disposal, there's a lot of new therapies, like I mentioned, new medications that are already FDA approved, vaccinations. If this is a sick protein, can you get the body to recognize it and help eliminate it and get rid of it? Can you do that through a vaccine, or can you also just do that through some other mechanism, helping the body fight this toxic protein, get rid of it, clear it out? Turns out, and I'll talk about it at the retreat, that exercise actually improves the elimination. It helps to eliminate the alpha-synuclein from both inside the cell and outside in the extracellular space. So that's extremely promising, and although there are so many new things in the pipeline therapies, there is no reason not to start exercising now. So get ready, because we're going to do a lot of it at the retreat. I just wanted to see what is alpha-synuclein, because it's this new, 10 years ago we didn't know what alpha-synuclein does, and they knew it was inside this Lewy body, but they didn't know, is that causing the disease? And it turns out, yeah, it may be one cause. So it's normally present in the synapse. So on the left you see those little yellow particles going in and outside the cell. Usually it's recycled and it has a role in the synapse. And then you see what happens to it as it becomes, it's not getting eliminated, and it starts to build up into these clumps. And you can see on the right here, these misfolded proteins, they start to aggregate, they have different names, and as they start to change shape, they become toxic. So at the top here, you can see the differences in the shapes of these proteins. They're a monomer, a dimer, an oligomer, a fibril, an aggregate. Those are toxic forms, especially the oligomers. And you then can see that the cells have lots of different garbage disposals. On the left, you see one that looks sort of typical. You run it through and it eats it up. There's another one called autophagy where it contains it, right? And eats different particles up. And then there's one that just constrains it like a ball or keeps it all together so it can't wander around and damage things inside the cell. So the goal for Parkinson's disease research now is to determine, can you improve these clearance mechanisms? Can you help the cell get rid of this bad protein? And then there's one more piece of information about alpha-synuclein that is new and has a huge impact on the cause of the disease. So not only do these proteins accumulate inside the cell like you saw on the left side of this figure, but then you see how it's traveling up that axon and it goes to another synapse and then it communicates with another cell and it's released, and the next cell takes up this bad protein and it's just continuing to infect neuron or cell after cell after cell as it moves through the nervous system. So this is called a protein infection, or it's similar to a prion disease. You might have heard that word in the literature. This concept was first published in 2013, and so it kind of explains why, if you put, if you do tissue transfer or stem cell research, you could put normal tissue inside the brain or a spinal cord and it may become sick with this alpha-synuclein protein over time. So there's this real need to control the, to clear and get rid of this alpha-synuclein and keep it from infecting cell after cell. So Dr. Brock, who's a neuroanatomist, and has been doing research since early 2000s, looking at post-mortem brains and identifying that this alpha-synuclein, because there's a marker for it, seems to be ascending the nervous system. It may not start in the brain. It may actually be starting lower down, even into the gut, the heart, other places, and moving into the nervous system. And so on the left, there are these stages of illness, you could say, where at first the primary system that's affected is in the brainstem, which controls cardiac function, blood pressure, sleep, sense of smell, and then it's not until it gets to the Brock stages 3 and 4 where you start to see sleep and motor disturbances. This is when the first signs of, say, tremor or bradykinesia may start. And at that time, there's already been a lot of other damage occurring at the lower levels in the nervous system. And over time, it begins to move up higher into the cortex, where you start to see more emotional and cognitive disturbances. So this hypothesis of how Parkinson's disease progresses is not really in the older textbooks. It's starting to be put in there now, but it has a whole new focus, right, for the how to treat Parkinson's disease and how many years people have been living with Parkinson's disease by the time they get to the stage of the disease where you have motor symptoms. And he anticipates, he was able to look at people who died from Parkinson's disease and then try to put together this puzzle of in different people after they are dead, or some people who weren't diagnosed even with Parkinson's disease, he could see that they already had alpha-synuclein building up in the brainstem, and it hadn't gotten to the point of the motor signs and symptoms being occurring. So what that means is that the motor symptoms that we all associate with Parkinson's disease are just the tip of the iceberg. That's what we see, but all that stuff underneath, those are the other parts of the brain that are already impaired and that probably have been for as much as 25 years. And this part of the brain is involved in lots of things to do with the autonomic system, sleep, like I mentioned, blood pressure, cardiac function, emotional and cognitive systems. So the more people understand these other symptoms that aren't as visible at diagnosis, the more they'll be able to diagnose Parkinson's sooner. So I went to the World Parkinson Congress in 2016, and there was a huge emphasis on the non-motor symptoms. And people are trying to look for early sleep disorders and constipation and changes in cardiac function, anxiety, things like this that may be good biomarkers for tracking that might show, so people could get involved in other kinds of things like exercise and medications. It's really important to talk to your doctors about these because there are a lot of treatments that could help these motor symptoms, non-motor symptoms, and truthfully, these are the biggest barriers to people to exercise programs, so they participate in exercise and are able to really exercise with high effort in the way we want people to. This is what keeps people from participating in life and doing the things they love. So there are new questionnaires that are out now, and I think I have one at the end to show you. We'll definitely talk about it at the retreat, because you can fill it out year after year, take it to your doctor, and it can really in that way you can be sure to get referrals to the appropriate specialists that can help you. This kind of research also suggests, right, that there are perhaps toxins out there that are somehow affecting our gut, making us more susceptible to this disease process. There's evidence that on the left that our vagal nerves can actually, that innervate our gut, that the alpha-synuclein is coming from the gut, going up through the sensory afferent and entering the spinal cord and moving up into the midbrain. Same with the olfactory system. There's evidence that it moves in from that process as well. You can find alpha-synuclein in people living with Parkinson's disease and in postmortem tissue. So again, these might be places to look for earlier diagnosis. One of the most promising are the submandibular glands. Perhaps in the future, when people get colonoscopies, they will be screened for alpha-synuclein, your skin, stomach, other kind of places like that. So there's research going on where they're brain body banks, and they study you over the course of your life. They take tissue samples, they do brain imaging, they do neurotests and imaging. And then when you die years and years later, they can identify what the cause of death was, and then they can go back over time and look to see when did alpha-synuclein start? When did the changes in the brain begin? When did the non-motor symptoms begin? So that's, again, studies that are looking for biomarkers. So this thing about Parkinson's disease beginning in the gut, actually, in 1817, Dr. Parkinson himself reported that some patients with the condition he termed at that time as shaking palsy experienced constipation. And in one of the cases he described, treating the gastrointestinal complaints appeared to alleviate the movement-related problems associated with the disease. So he was already just from his good observation skills and note-taking, recognizing that one, constipation is at making the symptoms worse, and doing treatments for that may improve the symptoms. And he was recognizing that the gut might have this constipation may have a real, be contributing or even a cause in the disease. Today, constipation is one of the most common symptoms of Parkinson's at diagnosis, and it often precedes the onset of motor symptoms. Dr. Brock, who we talked about, the neuroanatomist in Germany, he was the first to demonstrate the pathological changes may actually originate in the gut and end in the brain. And it's interesting, remember how I said that the vagus nerve innervates the intestines, and they track this alpha-synuclein going from the stomach, the lining of the stomach, inside and up through this nerve. People that have that nerve cut for specific types of illnesses have a lower risk of developing Parkinson's disease. So that does seem like it is a entry point into the nervous system. So at the retreat, we're going to have speakers talk about gut health and different new therapies, and I just wanted to give you an idea. The good news is there are a lot of ways that you could help get rid of alpha-synuclein. One, you could start with on the far left, with inside the cell nucleus. You could just prevent the manufacturing of alpha-synuclein by messing around with the DNA and the RNA sorts of interventions. That hasn't been done yet that I'm aware of, but you can also prevent it from misfolding and keep it from building up and aggregating. That's number 2. It may also be possible in number 3 to just dispose of the alpha-synuclein inside the cell, and number 4, dispose of it outside the cell. And exercise has been shown to do 3 and 4. The other thing is you can just keep the protein from being spread into the next neighboring uninfected cells. So there are some medications on the market. One of them can prevent it from misfolding to begin with. So it often opens up a lot of different possibilities for research. So to summarize, alpha-synuclein in Lewy bodies is the hallmark of Parkinson's disease, but now we know it may spread from cell to cell, possibly from gut to brain. It's a misfolded protein, and it's responsible. It's somehow not getting disposed of because this sort of garbage disposal system is not operating efficiently. There are drugs being tested in clinical trials that increase the clearance and keep it from accumulating in the nerve cells. There are vaccines and immunotherapies that may target the misformed alpha-synuclein and get rid of it. And then exercise may clear alpha-synuclein, and also exercise upregulates other neuroprotective factors like the neurotrophic factors, the stress, which may help these cells continue to operate better. Kind of provides a background, right, for neural health, for brain health. So if you want more information, you can go to clinicaltrials.gov. You'll have a handout in your retreat manual about this and more. And Dr. Nate McMullen and I will be talking more about this on Friday at the retreat. So I want to leave you with some really legitimate therapeutic options related to meds, deep brain stimulation, and more about exercise. So I hope you will get a copy of this medication table. It's from pdf.org on the internet. I'd highly recommend you get the hospital alert cards and medications to avoid. There's so many issues about people with Parkinson's going to the urgent care or to the ER, and the first thing that happens is they take away your medications, and you have certain rights, and so you need to be aware of that. And 2, they may give you wrong medicines that can actually really make your disease worse, and it become even life-threatening. So it's extremely important that you're prepared. There's a lot of different types of medication, dopaminergic medication, things that either starting from the top, MAOB inhibitors, they actually help you keep the dopamine in the synapse longer. So you use what dopamine you have better. You can actually just replace dopamine by taking levodopa, carbidopa. You can take something that mimics dopamine, which is an agonist. You can, the dopamine that you're taking, you can just help it to get into the cell and stay where it's needed. Amantadine is, they don't really know the exact mechanism, but it seems to increase the amount of your own dopamine that you release, and it may block reuptake, so it stays in the synapse longer. It also affects acetylcholine, so it's been shown to help people with dyskinesia. And then there are other things like anticholinergics, which have a lot of other kinds of problems with cognition and other side effects, but they can help with the tremor and may help with dystonias. So I'm not going to go into any more detail, but you can get a table that talks about each of those, and we'll have it at the retreat so it can help you ask questions of the doctors that are going to be there. There are certain side effects of medication that you really want to understand. Meds, these dopamine meds, they start to wear off. They should last around 4 hours typically. They may start to only work 2 or 3 hours. Sometimes they may just go off unpredictably, or maybe you do predict it, but and then they come back on again. So that's called an on-off phenomenon. Sometimes it takes them a while to kick in, so these delayed on responses. Some people begin to develop the involuntary movement, so you might feel good and you might not even notice that you're having these dyskinesias. But it's important to track those when they start and at what time of day, because there are things a doctor can do to optimize that and perhaps reduce them. And it's very important because the dyskinesias can really interfere with your fatigue, your whole lifestyle. It makes exercise hard, balance hard. And then there's a few new things like protein-related off periods. So if you happen to eat a highly dense protein meal, same time you take your medication, you're not going to absorb as much of the medication. And so these amino acids interfere. Turns out that plant proteins don't have quite the effect on absorption, perhaps because of the large amount of fiber. But again, we can talk to the nutritionist about that at the retreat. But it's really important if you really want to be routine, take your medications to help them last as long as they can optimally. You really want to be aware of this protein, the idea of what you're eating and when. Other things that can really interfere with quality of life are some of the dopamine agonists create these impulse control disorders where people develop compulsive gambling, hypersexuality, binge eating, compulsive shopping online at night, from beads to clothes to purses, whatever. It can be very, very subtle to an all-out behavior that can destroy a family. So it's really, really important that someone that you know when you take a dopamine agonist what to look for. Then there's this idea that dopamine is really an addictive drug, right? And there's a lot more of these short-acting dopamine medications. They're called rescue drugs, where you know, instead of taking them orally, and you can give yourself an injection, perhaps inhale dopamine, and it can become very easy to take these frequently, maybe too frequently, and it can impair decision making and social interactions, ability to work and carry on day-to-day routines. And the behavioral changes can be quite dramatic in that it's almost like instead of focusing on quality, right, people become obsessed thinking about their next medication and when they need it. So it's just something to be aware of and talk to the doctor about. and it was not even considered probably 10 years ago as a problem. So it takes a partnership to optimize your medication. It's complex, no one size fits all. The best thing you can do is to find a movement disorders neurologist, and I would say a Parkinson's specialized physical therapist for best outcomes. So studies have shown that people that see these two specialists have lower rates of admission to nursing home, lower rates of hip fracture, improved survival. You want someone that will focus on you and your quality of life, get second opinions, stick with the routine and the dosage. Do it right. Don't take it for granted. Don't just take it when you want. The medication changes, they may be required if your symptoms or side effects are new or different, or if they're not working anymore. But I highly recommend you try first sticking to a routine. Try exercise, because research shows people that exercise vigorously over time with these intensive bouts have a lower need for medication from visit to visit. And just because you go see your doctor doesn't mean you have to take and get a different prescription for medicine. So don't go with just whatever, if somebody says and gives you more meds, say, why? What is this going to help me with? Can I not manage this some other way? So ask questions. You're going to have this ongoing conversation throughout the course of the disease. There's new meds all the time. You want to know the latest. You want a doctor who's going to share that information and educate you. So I hope you can find a movement disorders in your area. If not, it's worth traveling, even if it's just once a year. My favorite movement disorders is online. You can buy his books, and he's at Mayo Clinic in Rochester. He has books that are written for you, the person with Parkinson's. He has books he writes for the primary care and the general neurologist. He's years of experience, and he has a really great philosophy. If you can read the one there, Cheaper, Simpler, and Better, you can get that online for free. And it's just his tips for treating seniors with Parkinson's disease. He has a very simple approach. And he recommends you should be optimally medicated as soon as possible and stick with that medication and exercise vigorously. So he is, if you really want more information than the article, I'd recommend the book, or it's partnering with your doctor to get the most from your medication. Take those papers to your physicians. They may not know about this. Optimal medications mean you can participate optimally in exercise. So that's the main reason to take medication, and that's Dr. Alskog's philosophy. I mean, it's important that your symptoms are controlled, which is the typical view, but it's more important even that you continue to do fitness and be involved in fitness and exercise and stay fully engaged in life. You want to continue. Are you doing what you love? Are you reinforcing the dopamine circuitry through targeted Parkinson-specific practice? We're going to use functional fitness as a way to target bradykinesia. You need to avoid inactivity and be aware of it. You come home from exercise and you sit and you do nothing else for the rest of the day. It's so difficult to reverse disability and loss of physical capacity or range of motion. So you need to continue to move and do things and participate in other activities that maybe you've stopped doing and go back and try them again. And you need to participate with vigor, and you need to feel like participating with vigor. So that's one of the key things I look for to give me a sense of, is a person optimally medicated? Can they completely activate their muscles with speed and amplitude? This study was done on people newly diagnosed, and they gave everyone a questionnaire to look at quality of life. Had a lot of different dimensions. But you see on the left, the drug-naive patients, 61 of them. And every time they came in over the course of a year and a half, their quality of life was worsening. That's why the scores are higher. The individuals who at diagnosis were given at least some type of dopamine replacement, levodopa, a dopamine agonist, or an MAO-B inhibitor. showed a better quality of life over time with really no worsening. So that's a huge indication of how much change can happen quickly, and if your quality of life is worse, you're not going to be participating in life or exercise or doing all the things that you need to do to stay active. There is evidence that the earlier you start, the better your quality of life is, but it's not too late to get started. That's why I like this study. This was from a database of 3,000 people with Parkinson's from the National Parkinson's Foundation Centers of Excellence, which are all over the US and Canada. And every time people went, they were asked to complete the quality of life measurement. And every year they'd come back and do it again. So if you see on the left, if they were an exerciser at baseline and every year afterwards they continued to exercise, they had no change. Their quality of life stayed good. So that score changed from 0 to 1.8, very minimal difference. If you look at the group that said, no, I don't exercise, I never want to, and the therapist couldn't talk them into it, year after year, their scores increased to 6.2 over 2 years. So they were doing worse on quality of life. And then you see in the middle, those are the two groups who they changed their minds over the 2 years and did start exercising, and they were able to kind of catch up, right? Their scores were not as low as the group that said no, no, no. All right, a couple more. So when your meds are optimized, you can actually produce more effort, more vigorous exercise. It increases your tolerance for effort. It makes it you more willing to work for a reward. So that's one reason you need to have your meds optimized so you can, again, fully participate and benefit. This was the first study ever to show that people that participate in intensive bouts of rehab once a year required less medication. So this is a group out of Italy, and they had people receive PT, OT, and speech 3 hours a day, 5 days a week for a whole month, and every year they did it again. And so that's 60 hours per year of intensive exercise that was Parkinson's specific, skilled, targeting those dopamine circuits, aerobic exercise. And on the right, you see that 2 years later, the bottom line represents the group that had it's called multidisciplinary intensive rehab therapy. And that line represents how much total dopamine replacement they were taking compared to the control group, which you see is much higher. So the doctor would see them every time they did their intensive therapy. He would see them and he'd say, you're doing so good, I don't think you need more medication. Or maybe I'm going to take you off a little bit because you don't need it anymore. You're moving so well. So a partnership, optimized meds, optimized exercise, the best results. So how do you know if your medications are optimized? First, quality of life. How about your energy, your sleep patterns, your pain, quality of your movements? Do you have full range of motion? Can you fully activate and get into your good posture and use your spinal range of motion? Do you have cramping or involuntary movements or hallucinations or greater anxiety, panic attacks, freezing of gait, worsening speech or swallow? Those are the things you want to talk to your doctor about, and you want to target them as soon as possible. Don't let them continue. Try to find a way to reduce them and find out what you can do. So meds are not enough, right, to really have optimal wellness and optimal recovery. The medications will help you with your motor symptoms, your rigidity, the bradykinesia, the incoordination, but the medications will not help you with your emotional symptoms, anxiety, the problems making quick decisions, the sleep, the blood pressure. However, exercise has been shown to help with emotional, cognitive, and autonomic problems, all these non-motor symptoms. So I just hope you'll start with exercise when those things happen. This is a review article that talks about how exercise in Parkinson's disease can target all of these different things. If you look at that list, there are so many things on there that people with Parkinson's they live with on a regular basis. And exercise has been shown to help. This article was written by a group of movement disorder specialists, and they agreed that this is why people with Parkinson's should be involved in vigorous aerobic exercise. Fatigue, constipation, improved sleep, better cognitive function. So they've tested all of these. They put all the studies together and then summarized them. This is that questionnaire that you can get online. It's called the Parkinson Disease Non-Motor Scale Questionnaire, NMS. It looks at 30 different symptoms, and it has you just simply rate yes or no. And whether you have 5 of these or 15 of them, you need to track these symptoms, be aware of them, talk to your doctor about them, get referrals. There are community resources. There's pelvic floor therapists that can help with urinary issues and bowel and bladder and constipation. And there's acupuncture. There's lots of different things out there. So I've made a list of questions. We're going to talk about them, but you need to have a way to start talking and open a conversation with your physician. So you want to know when they say, here, take this, you want to talk about, well, why am I taking it? What symptom is it helping with me? What are my other options? How will I know if it's working? Can I stop it? How do I stop it? Are they addictive? How do I know if I'm starting to take too much? How long should I expect it to work? These are all great questions, and so hopefully you'll have this in a handout. You can take that to the doctor. You can also go to the Davis-Finney Foundation, and they have this amazing book I'm going to show you. You can get it for free. They ask for a donation. It's probably the best book of all this information I've ever seen. They have worksheets in there, medication logs. They have a way to track your symptoms and checklist for your doctor. So Every Victory Counts manual, that's the name of it. Davis-Finney Foundation. He has a young onset Parkinson disease individual. He is a pro cyclist, and he's all about wellness and exercise. And this book, Every Victory Counts, is well worth the effort to get, and they'll mail it to you. So just a reminder, you need a medication log. There's one in that manual. You can create your own. And last, I want to just mention that deep brain stimulation is another option for people, and there's so much improvement in the type of stimulators that are available now and the type of surgeries. There's surgeries where you're awake or you're asleep. Some of the stimulators are more focused and can be directed and targeted better than others. Different surgeons, though, have not all learned the newer techniques, so you need to sort of ask what is their preference and why, and what is the process. The most important thing is, if you're a good candidate for deep brain stimulation, then yes. But you need to go through, ideally, a multidisciplinary team. You need to be assessed by a therapist, a speech therapist, a psychologist, psychiatrist, and a neurologist, movement disorder specialist, and probably the neurosurgeon. You need a team, because if you aren't the right candidate, it cannot be a good, positive thing. And it is brain surgery. I hope you've tried exercise before you start that. I hope you've been to rehab and done intensive therapies. Those are the kind of things I would recommend if I was screening people for DBS. I'd be looking for, do you have freezing? Do you have trouble with speech and fluency? Do you have problems with swallowing? Are you having cognitive issues that could be all of those things could get worse? Do you have problems with balance and postural control? Could get worse with DBS. The best candidate for DBS are those people that when they take their medication, their dopamine medication, they feel it. It kicks. If your dopamine meds are working, the best they work is about as good as the deep brain stimulator will do. So when you're on with your meds, that gives you a good idea of what a stimulator might do. And then you can sometimes take away the medications, or you can continue to add a little bit. People that have a tremor, the deep brain stimulation really helps with the tremor. For those people that have, they respond to the medication, but it wears off and they just can't find a way to keep their medications constant over the day, and they're having these fluctuations, and it's really impacting quality of life. Those individuals are often good candidates. So I recommend you go get second opinions, talk to other people, and my favorite place to go have people go is to this dbs4pd.org there at the bottom. That's a survey of thousands of people who have had the deep brain stimulator. It's people with Parkinson's telling you in a survey what it was like, how it feels, what it seems to help with, what happens afterwards. It's a great thing to read before you make a decision, or before you start asking a lot of questions, so you know what to ask. If you just want to know about the surgery in general and just general information, go to the National Parkinson's Association. They have, most all of the associations have information about deep brain stimulation. That's more technical, but I highly recommend that survey by the dbs4pd.org. So it's time for new paradigms in Parkinson's. There's been this problem that as a physical therapist and in terms of exercise, people never get us. They never get exercise until they start to fall or have an injury. So that top line represents the stages of Parkinson's, from diagnosis, where the symptoms are on one side of the body, and then by a stage 2, they start to go to the other side. It's not till people get to a stage 3, when they're falling, that we see them. That's years later. And yes, we can help at that point, but ideally, we'd like to prevent the falls and put off that loss, that motor deterioration that's happening. So we need to start with people at diagnosis. And in the future, when there are more biomarkers, I hope I even get to start with people before they have motor symptoms. Can we help them start exercising even early, before the symptoms? You hear all this talk about, is exercise disease modifying? Can it slow the disease? And my answer would be, with our current healthcare paradigms, no. No matter what class you do or how many times you go a week, one class is not going to slow disease. You need to have access to an ongoing exercise prescription for life. You need to have someone modify that prescription. Then you also need to have targeted practice and skilled practice on specific issues across your life, with rehab, ideally every 6 months. You need to be assessed with, you need to know what's going on. And it's an exercise prescription, and it may change over time, just like your medications. That is how we're going to slow disease progression, by keeping you optimally moving for the course of the disease. And it's not easy with our healthcare system. It's not even something that's really available in very many places, if anywhere. We're doing our best in Tucson to provide ongoing access to exercise and rehab for life, but there's still the issues of payment for rehab and the willingness of people to fully participate. So what does your exercise prescription look like? Well, one, come to the retreat and you're going to find out. We want to optimize positive brain change. We want to design a targeted approach to exercise to target Parkinson-specific skills, and we want to be your lifelong coach to help you manage your exercise prescription. Every time you see your physician to help you with your medications, you should be going to your therapist to get your exercise prescription updated. There's times during the course of the disease they may say, you know what, we need to work for 3 or 4 weeks on these problems before they get to really impact your life and keep you from exercising. They're interfering. They're beginning to interfere. Let's work on them. So intensive rehab bouts, and then referrals back and forth to the community, to facilities or to individuals. We're lucky to have a community-centered facility, but there's lots of classes all over in the YMCAs and at different organizations. So you'll learn more about an exercise prescription when you come to our retreat, so I'm not going to talk through this, but you're going to experience it firsthand, which is the best way to learn. Just do it. And we'll see you soon. And I can't wait to meet those of you I haven't met yet. Many of you are coming back, and it's going to be a fun party. So we'll see you in about a week. And I hope you have time to watch this. So thank you.